taken earlier to study this matter. And so this is our first meeting, and I want to welcome the panel. I see three unfamiliar faces and one familiar face. So maybe I can turn to Lieutenant General Lise Bourgon and ask her to introduce her colleagues and whether it's she or someone else, your opening 5-minute statement, please.
Merci.
Thank you very much, Mr. Chair, and good morning to everyone.
I come here too often since you know me.
You're a veteran. You're a veteran. Yeah.
So, as you know, I'm Lieutenant General Lise Bourgon. I'm the acting Chief Military Personnel, Commander of Military Personnel Command. And first this morning, I would like to acknowledge that we are gathered on the traditional unceded territory of the Anishinaabe people. En tant que CMP,
as acting CMP, I am responsible for recruitment, training, retention, education, career management, policy, pay and benefits, health services, military career transition, morale and welfare programs, and a host of other corporate and personnel support services. Very comprehensive.
By three of my senior commanders. First to my right, Major General Marc Bilodeau, the Surgeon General, who is the medical advisor to the Chief of Defense Staff and Minister of National Defense, and is also the functional authority for the professional and technical aspect of the medical and the dental care to our members. Brigadier General Scott Malcolm, Commander of Health Services Division, whose responsibility is to deliver health care to CAF personnel, ensuring their readiness and enable CAF operational success through the provision of agile health service capabilities around the world. À ma gauche,
to my left, I have Commodore Daniel Bouchard, Commander of the CAF Transition Group that provides military career transition services to serving or retired members of the CAF, as well also as healthy, ill and injured members, and also to the families of a deceased member.
Committee for your interest and better understanding our military health system, the provision of health services, and the transition support to our members. These are indeed important topics because first and foremost, we have a duty to take care of our people who put service before self.
Unlike any other institution, the provision of health care to our members is the responsibility of the Canadian Armed Forces and not the province or territories where they reside.
All of us here today are focused on providing the required supports and services through our member through all aspects of their military careers, whether they are healthy, ill, or injured, transitioning to civilian status, or deployed on operation. Our priority is the long-term health and wellness of our military members and providing high standard and quality health care to the full diversity of the CAF. This is achieved primarily through the Canadian Force Health Service Group, which is responsible for the care and well-being of about 64,000 regular force members, as well as our reserve forces members on operation or on full-time service. Les services des soins des forces canadiennes.
CFHS, the health services, a key enabler to our military missions around the world through pre-hospital care, primary and surgical care, as well as specialised care.
CFHS provides health services through 37 primary care clinics across the country. 31 of those which offer specialized in-house mental health care. The multidisciplinary teams of mental health care providers include social workers, mental health nurse, psychologists, psychiatrists, addiction counselor, and mental health chaplains. Le programme de
The CAF's mental health program has been recognized by our NATO allies and civilian organisations for its very robust approach to mental health care, as well as stigma reduction initiatives and its mental health research, training and awareness programs.
The Road to Mental Readiness program, launched in 2007, promotes mental resilience and improves mental health awareness. Nous avons aussi un programme spécialisé.
We have also a specialised program called Resilient Plus for the military colleges, which specifically aims at academic youth.
Jobs. Sometimes our members become significantly ill and injured. Whether their injury is physical or mental, they may require enhanced support through a return to work program, transition within the CAF, or, sadly, to post-military life. C'est une des raisons.
That is one of the reasons why SSE 2017 directed us to create the CAF Transition Group in close collaboration with Veterans Affairs Canada and other valued partners. We now have 32 transition centres at bases and wings across Canada. And the CAF Transition Group staff work to offer the best possible service and best possible support to all Canadian Armed Forces personnel and their families to prepare for, and at the appropriate time, complete a seamless and successful transition to civilian life, and when the time comes, to carry that out well.
That transition does not automatically mean leaving the forces. CAFTG offers services and programs to support, first and foremost, the return to duty to our members, whether that is by reintegrating them back into their home units or helping them transfer their skills and experience to new career paths within the CAF, such as through occupational transfer.
General Bourgon, are we close to the
I'm
the end?
almost done.
Okay.
Okay. So we know that we have more work to do to continue to provide quality service to our members. That is also why we are working to improve the spectrum of care that we provide and how it is provided, especially on service and support for women and diverse members. I think that Budget 2022 announced $144 million over 5 years to expand the CAF health services and physical fitness program to be more responsive to women and gender diverse members. On prend aussi des mesures.
We're also taking concrete steps to make our health resources and services more inclusive. For example, we have reviewed our transgender care program to make it more inclusive and comprehensive for our members.
We continue to work with our women members in a person-partnered care to identify gaps and needs in order to action them. So whether our personnel are on the road to recovery, rehabilitation, returning to duty in the CAF, or transitioning to civilian life, we are committed to assisting them in our journey. Donc, encore une fois, nous...
So thank you once again for having given us this opportunity to appear before you today, and we welcome questioning from the committee.
Bourgon, it's not even 9 o'clock and already I've cut a general off. With that, we'll start with Mr. Brizan, and hopefully we'll not... It is Mr. Brizan, isn't it?
Thank you, Mr. Chair, and I want to welcome our witnesses. For the new ones, welcome to committee, and for General Bourgon, good to see you back. You had mentioned the JPSUs that we had stood up as part of Road to Mental Readiness and helping with that transition. Now, JPSU no longer exists. There's a new format. Can you just explain how it is for those that are medically releasing for either visible or invisible injury? How do we handle them specifically?
Yep. Mr. Chair, thank you very much for the question. And I think I will give the floor to Commodore Bouchard, who it's his job to be the leader of the CAF Transition Group. Dan?
Thank you very much, Mr. Chair. Sir. The JPSUs, as you said, were stood up in 2009 to assist our ill and injured in their transition and their support. Currently, in 2017, we stood up the SSE, Strong, Secure, and Engaged, recognized the requirement to increase the support to our members that are transitioning. And in 2018, my organization, Canadian Armed Forces Transition Group, was stood up in order to provide that support. We have developed a process called the military to civilian transition. All regular force and soon reserve force members will be transitioning through our organization to civilian life. But our priority, our primary focus also is on retention. So as General Bourgon was saying, we've stood up in 9 regions, 32 transition centers to support the process of transition.
They don't have to report in like they used to under JPSU, be part of a unit. They still, weren't required to parade or be on exercises or training or anything.
That is correct.
Yeah.
That is correct. They are employed in accordance with their military employment limitations. Some can continue on with some parts of work, and the idea is to reintegrate them as best we can.
Okay, and
into the
release
workforce.
happens when everything's been assessed. Do you hand them off to Veterans Affairs with pensions in place as well as, or do they still have to sit and wait, sometimes months and years, especially for our reservists, before they receive a pension or any of their disability benefits?
So with our new processor at the TC, it's a holistic approach, and we have Veterans Affairs Canada embedded with us to better support our members as they transition. So for our ill and injured, they are supported by a service coordinator who provide them a personalized approach across the services that they require, and we ensure that the services will transition with them if they are releasing from the Canadian Armed Forces.
Okay. Going to switch gears a little bit here. When we are deploying our troops to places like Latvia, Kuwait, Poland, in the UK right now, do we provide our own medical teams to accompany them, or do we rely on allies to provide their medical care?
The answer depends, but mostly we have our own integral medical resource. So, General Malcolm, you might want to add here.
Mr. Chair, thank you very much for the question. So as it stands right now, in terms of support to operations, on operations impact, reassurance, union, and projection, all of the medical personnel deployed there are in support of providing supporting medical care to our troops on the ground. It's only in our other operations where they're there as trainers. Thank you.
Okay, so in Poland, where do our guys go for medical attention if they get a sprained ankle out in theater? They're out there training.
So we do have.
You have guys.
We
so
have
medic.
internal
Is it like what level? Is it a medic? Is it a doctor? Or is
So
it a nurse?
our trainers right now are typically med techs and med A's, all capable of dealing with your basic medical issues that our folks are going to run into.
Okay, so somebody had operational stress injury while they're serving abroad. What process comes into play then?
So if they've faced a traumatic event or a stressful event,
Yeah.
so in that case, the first assessment is always with our med tech or the next available provider. And if it's outside their scope to deal with it, then it would be referred higher. If there's no one in the immediate area to support them, they can either be referred to local civilian care or, if necessary, repatriated either back to Canada or perhaps in this case, if they're in theater, to one of our locations like Geilenkirchen, where we have a clinic.
Okay. Now, we know that recruitment's been an issue and that we don't have all the troops that we need, whether it's soldiers, sailors, or air crew. How has the recruitment crisis affected health services?
Yeah, thank you, Mr. Chair. Really good question. And as you're all tracking from a chief military personnel, recruitment, retention, and training modernization are my number one priority, all as important. And indeed, the medical side have suffered the same way from the recruitment side and the retention. So I'll pass the floor to General Bilodeau, who might be able to talk about, specific recruitment and retention effort targeting.
Historically, having psychiatrists, psychologists.
Les psychologues, les psychiatres, etc. ont toujours été difficiles à recruter. Cela a à voir avec la géographie et la rémunération. Naturellement. la crise généralisée de la santé mentale ne simplifie pas les choses. Très bonne question. Il faudra malheureusement que j'y réponde à un autre moment. Vous avez 6 minutes. Jennifer, vous avez 6 minutes. Désolé, Monsieur le Président.
Ouais, 6 minutes, s'il vous plaît.
Thank you, Mr. Chair. Did you hear? But I can't hear anyone else, so it's not just for me, it's that I can't hear the witnesses.
So
So
wait,
can you just make sure that that's fixed?
so do you want to move on until we correct that? What's the issue?
No, I can answer, but I'm just saying that it's translating in French, so I can't, it's turned off the sound to hear the answer. So if that can be corrected before I start.
What's that? Okay, can you talk about the weather for a second?
Hi, Mr. Chair. I'm home in my riding. It's beautiful and sunny.
Okay, it sounds like it's fixed.
Okay, thanks so much.
Okay.
Thank you. Thanks, everyone, to all of our witnesses being here. General, you spoke in your opening comments or your opening statement about some of the gaps, in particular around women and persons of diverse backgrounds. Can you elaborate on what some of those gaps are? And I would think that gaps to health services, in particular for women and diverse persons, that this is something, you know, women in the Canadian Armed Forces is not new. So I'd be very concerned to see why there would be gaps existing currently, or how long those gaps have existed for. So perhaps could you elaborate on what some of those health service gaps actually are?
Thank you very much, Mr. Chair, for the question. And indeed, you know, when we look at the CAF, and some of you have heard probably me said it before, the CAF was built for men by men. Those are the policies, that was the services that we provided to the majority. And that's what we need to change. And we are changing to become more inclusive. So a big part of that is looking at the health services and do the gap analysis and come up with programs where, again, women and diversity will feel valued, and we will look at each individual. So là-dessus, I think I'm going to pass the floor to General Bilodeau, who's responsible for the Women's Health and Diversity Fund.
Yeah, thank you, General Bourgon, Mr. Chair. So that gap in women's health data and research is not unique to the military. It exists in society. You know, most of the research in healthcare, unfortunately, historically has focused on male, and there's very little data in many conditions related to women. So obviously, we're impacted by that in the military, which means that more research is required, and in order to inform better care for women, and that goes from prevention of injury and diseases, but also management of health conditions in a military environment, which is the area that is unique to us, where we need to study more. We're doing an honest job regarding women's health. You know, when we look at our screening, you know, for breast cancer and cervical cancer data, for example, we're in par with Kenyan society. Having said that, we can do a lot better. And that's why, you know, we're very fortunate to have been funded through the last budget with a significant amount of money to build a women's health program. A women's health program that would be based on 4 pillars. One of them being improving the health care that we provide to our women. That speaks to the quality of the care, but also the spectrum of care itself, because there's some items that are currently not covered that women would benefit from it being covered. Looking at injury prevention, and for that we're in partnership with our partners for Director General of Moral and Welfare Services, who are basically our fitness providers. Research and engagement, I spoke about research. There's lots of gaps there, and that's where we're going to engage with our research partners in order to fill those gaps from a research perspective and have better data to be able to monitor the health of our women, but also monitor the efficacy of our preventive measures and treatment measures. And finally, we need to measure what we do. We need to have better quality and performance measurement regarding the health of our women. We lack data, and we need to build that data in order to make sure that what we do leads to improvement and better results ultimately.
Thank you. And in a previous answer, it was stated there are clinics around the world for serving members that if the services on the ground or for the mission, can accommodate the injury, that a member can be moved to a clinic. How many clinics are there around the world? And is it in relation to how many missions there are? Could somebody perhaps elaborate on what those clinics look like, how they are employed? Are they CAF members, or do you rely on the local expertise to staff those clinics?
Thank you very much. Excellent question. Well, it depends on the location of our troops, but with allies in some areas, and I'll give the floor to General Malcolm after. Some areas we have our own clinic, but some areas we only have like medical support, our own integral medical support. But we can also tap in the environment. So if it's a NATO alliance, then we will use other alliance medical capability. If we're deployed around the world, in some countries, we will also tap into the national medical services, depending on where we are. So, Scott, do you want to add on to this one?
Thank you, ma'am. So just to carry on, so in Canada proper, there and including our clinic in Geilenkirchen, Germany, and in Shape in Belgium, we've got 37 clinics, and we would characterize those as an enhanced primary care, meaning that you don't just have access to doctors, nurses, physician's assistants, and nurse practitioners, but in most of those clinics, you have access also to a pharmacist, in some of our larger centers, to X-ray, in some of our largest centers, CT scan. You also have access to lab, and in 31 of 37, you also have access to mental health services, which could include psychiatrists, psychologists, social workers, and mental health nurses. So that's why I would say it's more of an enhanced primary care. And when we look at our overseas deployments, so currently in Kuwait, Latvia, Poland, we do have, and as well in the Indo-Pacific on our ships, we have integral medical support, meaning that's provided by our folks. Now, both overseas and in Canada, as was alluded to by Lieutenant General Bourgon, if there's a service that's required that's not immediately available or is not of the right type, we're able to refer out, whether it's in Canada to our civilian partners or overseas to validated local.
Unfortunately, we're going to have to leave the answer there. Thank you.
Thank you.
Madame Normandie, 6 minutes, s'il vous plaît.
Thank you very much. It's always a pleasure to have you. Thank you for being here. I'd like to come back to what Ms. O'Connell has just said about the status of women and the transfer of information between the forces and other entities. I was at Veteran Affairs Committee yesterday evening, and they raised that as a challenge, namely the data collected by the forces are not always transferred on correctly to Veteran Affairs. We know that many women are released for medical reasons because, for example, the equipment used by women is not always adapted to their situation, although things are improving, but that's still an issue. So from Veteran Affairs, it seems that it's more of an insurance policy dealing with the symptoms rather than the causes, because there's not a feedback loop. So I'd like to know, is this an issue that you're aware of, and how do you actually manage that? Thank you very much, Mr. Chair. That's an excellent question, and we need to continue to make efforts in this area. We know that we have some gaps when it comes to information transfer, and with the working group with VAC, that is one of our working groups to try and accelerate and facilitate the transfer of information. We also see that we'll have to do this in the future with provinces and territories as well, because this information is essential for treating our veterans once they've left the CAF. So perhaps I can turn to General Bilodeau, who can give you some specific examples of what's happening and what we're looking to do in the future to improve this gap. Yes, thank you very much, Chair. It is a major issue as a Surgeon General, because I have to ensure the security and quality of care, and quality of care is impacted negatively if we don't have that correct transfer of information. It's critical within this context to have good transfer of information. We've got an initiative underway at the moment where we've been able to give access to electronic medical files that we've got within the CAF and give that access to workers within Veteran Affairs to facilitate the transfer of information. So that's between two federal departments. When we talk about the transfer of information between a federal department and provinces, that's a different kettle of fish. It's not easy to manage this because we have to come up with 13 different solutions for the 10 provinces and 3 territories. So there's lots of work still to be done. Of course, for the moment, in order to facilitate this, we give them a copy of the medical record to the member when they're released so that they can have this information transferred. But we can't do it electronically yet. So there's not an electronic medical file per province. Some provinces have this, but most of them have a multitude of e-medical files. So that's something we're going to have to really look at closely to ensure security of that transfer of information. Thank you very much. So I'd like to come back to that. Even if we transfer the medical file towards a province, we hear two things. First of all, there's not enough physicians in provinces either, and that's where it's critical for these first 2 years, where the new veteran is finding it hard to find a physician, or even physicians say, when I have access to medical record, from a deontological point of view, I have to redo this process. So could there be certain initiatives put in place which would mean that a new veteran could have access to the forces services to allow for this transition for 1 or 2 years? Is it something that's been analysed? Is it a question of resources, a monetary issue? It's a big preamble, but I'd like to hear about this. Certain people have told us that they've got expertise in the forces as a physician assistant, a PA, but they cannot work on the civil side because the profession is not recognised, but they could actually serve the federal department and help with the transition. So are these options that you can envisage? Yes, thank you very much, Chair, and thank you for that question. Yes, this is an issue to transfer this to the civilian side because there's more demand than capacity to meet all of these needs on the civilian side, as you no doubt know. We have certain internal mechanisms which allow us to keep our members in uniform for a longer time to make sure that they have a safe transition, and we manage that in partnership with the transition working group to make sure that it's not just healthcare but all the support services that are offered so that we can bridge all of this situation with the availability of resources outside of the military. And there's different initiatives with Veteran Affairs in partnership to facilitate access to a family physician when they leave CAF. Thanks to a partnership with the College of Physicians of Canada, we developed a document so they can facilitate the understanding of what it means to be a veteran, to explain that to family doctors so that they are more enthusiastic about becoming responsible for these released military members. And then this question of using all types of personnel from all sources, that's something we're considering. And physician assistants are becoming more and more popular. The majority of provinces are going for this approach with physician assistants, and the provinces that haven't launched that are contacting us to ask about our experience because we've been doing that for 50 years. This is a profession that we know well, and we know the benefits of this profession for our healthcare system to try and get around these bottlenecks in the primary care system. Just to add something, the transition group, before someone is medically released, there's an evaluation that's carried out to make sure that there is a capacity to transfer to the civilian medical side. They're not just released and into the jungle. They've got support, and we make sure conditions are in place and that this person is ready to be released. That's the beauty of this transition group, where we really manage people on a case-by-case basis, individually, depending on their personalities. And we've also got a MAPLE service, which gives this transitional service for people who are released from the armed forces, but who do not yet have access to services in their own province. So it's a telemedicine, remote medicine service.
There, it would be, just so that I don't continue to cut off a bunch of generals, just look up here every once in a while. I'll try to indicate where the time's at, and that way I don't feel I'm interrupting on what are important answers to important questions. Ms. Masson, your important question, please. 6 minutes.
Thank you, Mr. Chair. Actually, just to continue on with that, I think that conversation was a bit more in terms of general medical practices. But if we could talk about the transition for mental health services, when someone is going through such specific trauma or circumstances dealing with mental health, the relationship with their care provider is often unique, and it takes a lot of trust. And so how is the transition group working in terms of that continuity of care? Because just to stop care specifically for people with maybe a higher traumatic issue that they're dealing with and so on, how do they work with in terms of that continuity of care? But also, I mean, the telehealth may be okay in some situations, but certainly not in others. So how do you said you were dealing with that on one-on-one, but specifically with mental health?
Thank you, Mr. Chair, and you can interrupt me anytime you want. It's okay. And there's services, and there's. Yes, there are services in place, OSIS, which the Operational Stress Injury Group that provides that service. And I'll turn the floor to Commodore Bouchard to provide a little bit more information on what this service does.
Thank you very much, ma'am, Mr. Chair. Yes, OSIS, the Operational Stress Injury Social Support, it's a partnership program that we do with Veterans Affairs Canada. So it's a group of 70 managers, coordinators with 70 volunteers. They have lived experience. They are on their own journey also assisting our member through this difficult process. So it's a one-on-one group peer support that provides it with these volunteers. It can be done virtually, in person. It can be done on the base, but it can also be done on a civilian establishment off base, which sometimes is required to have that further on discussion. And on average, we'll support about 2,000 peers. And that's divided by peers, and it's also with their families. The families are invited to these support systems. And 20% will be serving members, 11 are the members themselves, with 9% being their families, and the other 80% is our veterans. 55 will be veterans themselves, and 25% will be the families that can accompany on these services. So on average, 2,000 peer interactions that we have to support these individuals throughout. And again, it's in partnership with Veterans Affairs Canada.
And I'd like to have, Mr. President, that we also have our network of operational stress injury clinics that are Veterans Affairs led and funded clinics that are all over the country that are specifically designed to take care of our members who are releasing who have mental health issues. We have a close partnership with those clinics through a memorandum of understanding that we have between our military clinics and those OSI Veterans Affairs clinics, and that allows us to do a safe transition of care specifically for mental health issues for our members, on top of the peer support program that Colonel Bouchard spoke about.
In terms of healthcare providers in the military, how do they balance the obligations and the principles that they have to face with their medical licensing bodies versus their military directives? What barriers do healthcare providers face in terms of finding that balance?
Thank you, Mr. Chair. And on that one, I'll give the floor back to General Bilodeau.
Thank you, Mr. President. Thanks for the question. So it is a challenge that all of our healthcare providers are faced with because obviously we're first and foremost healthcare providers, and we need to be there for the patients in front of us, making sure that we're providing them with the right level of support from a diagnostic treatment perspective, follow-up, recovery, and so on. But we also have an obligation for the employer, basically, to make sure that whatever how these members are employed is in accordance with their medical condition and the medical employment limitations that we're obliged to provide to the employer. So I would say that in most cases, this is something that could be managed and managed not too many challenges, because we always put our patient first. So as providers, we have an obligation, and I have obligation for my college who are giving me my license to treat my patient first. So that obligation to the employer becomes usually second. It's not less important, but it's just a second consideration after the first one. This way, we're ensuring that it's the care and the health of our patients that is considered before everything else, and secondly, the security of the armed forces and its mission, basically.
So, I mean, this has come about a lot, especially Justice Arbour spent a great deal of time in her review into the details on the impact of duty to report, specifically for healthcare providers. And at that time, there was a working group that was considering the exemptions for provincially regulated healthcare providers to ensure that there was that balance, that medical need did outweigh military service or the requirements of service. So she made it really clear in her report that the duty to report was actually, it needed to be abolished outright. Can you, or can one of you update the committee on that working group and the impacts around the duty to report in the medical environment and what's going on there?
Again, a important question, but when you have 1 second left to answer it, it's probably not going to work. Colleagues, we need some collegiality here, because otherwise I'm going to end up cutting you off all morning. With that, Ms. Nyman, please don't let me cut you off.
Good morning. Thank you, Mr. Chair, and thank you to all of our witnesses for being here today. My first question, perhaps General Bourgeon, can you speak to the effects that the current PSAC strike is having on service delivery to our CAF members, particularly regarding the Sexual Misconduct Response Center and grievance officers?
Mr. Chair, that's a very good question. I am not tracking the impact for the SMSRC, but I can certainly give the floor, if that's okay with you, to General Malcolm, who can talk about the impact that it has on our health services right now. Scott?
Mr. Chair, thank you for the opportunity to respond. So as it stands right now, we're tracking that our clinics across the country are still able to deliver the services to our patients. With the absence of our public service employees, they're mitigated by uniformed members. So we're able to carry on with the delivery of care. Thank you.
Thank you. Then switching gears, can we speak to systems that are currently available to provide healthcare supports for spouses and children of CAF members? And in concert with that, how do these supports adjust for the frequent mobility of military families due to being stationed in new locations regularly?
Thank you, Mr. Chair. Really, really good question. When we looked at the mandate of the healthcare services for our members, we provide support to families, spouses, and children through using services that are being provided by the Canadian Force Morale and Welfare services. So they are provided funds to liaise at the base level and provide support, mental health support, educational support for our children to again provide that support, because again it is difficult to move every 3 or 4 years. I think that Seamless Canada is a great working group that hopefully everyone is tracking the work of all the provinces and the territories, working with CAF and D&D, looking at those 3 files, like spousal employment, child care, and health care, so that we can look at and smooth the way for our families when they're asked to move across provinces. So great work is being done. I think it was established in 2018. The next one is in Gagetown in May, but really working hard on those 3 lines of effort and small steps, but huge step at the end of the day for our CAF members.
Okay, next question then. So Does that suggest then that the CAF has been working with provinces to ensure family doctors are more readily available to military spouses and families living on bases in rural and remote areas?
Yes, but not CAF. More the SMRCs, again, are liaising, coordinating at the local level, trying to work with the local communities, with the availability at the tactical to try to make sure, facilitate our families getting access. So it's more of a service being provided, and we're not doing it from a uniform perspective and a CAF perspective, but the service for coordination at the local level is being done. Yeah.
Do you think the lack or the concern of support in this area is undermining recruitment and retention overall?
Well, again, we are looking at everything to improve our recruitment, and this is part of the things that we need to continue working with the provinces, the federal, and the territories on how we can just keep working and making the situation better. But it's a problem across Canada, so we're just a player in there. But yeah.
You had been cited as saying that we're presently 16,000 members short of authorized regular and reserve force strength of 101,500 personnel. That may be causing higher attrition rates. And to what extent could a lack of military support be impacting these attrition rates? So could you speak to, in addition to that, what types of professionals you're looking for in recruitment? What types of healthcare professionals?
Well, we are at this point, out of our 71,500, we are about 8,000 Reg Forces members short. Okay, so that is the stats. Again, looking at recruiting Canadians, we have to change. Let's be honest, the last 3 years have a little bit hurt the reputation of the CAF. So we need to regain that reputation. We need to connect with Canadians again. So we need to change. And I think the recent culture evolution and all the initiatives that we're coming up with is really making a difference, bringing new Canadians and Canadians into the recruiting center.
So just to complement that.
Sorry.
I'll save it for next time.
Save it for next time. There's going to be plenty of rounds. We've got these folks for 2 hours, so we can go back on it. Madame Lambropoulos, 5 minutes, please.
Thank you, Mr. Chair. Thank you to our witnesses for being here with us today. This was a study that I had put forward, and the main reason why I had put it forward was because when I did sit on Veterans Affairs several years back, there were clear concerns that I had that have been raised already, but I did want to push a little bit and see if there's more information that we can gather here today. At the time, officials from Veterans Affairs were saying that it's very limited in terms of what information they can receive about these veterans' medical history within the forces. And it was very much up to the veteran to go and seek help. There wasn't anybody reaching out to them. There wasn't a database of people that, should be checked on every couple of years. It was very much up to the veteran to reach out for help. And so clearly there's a lot of work that needs to be done there. One of the recommendations that we had made in that study, which only went to Veterans Affairs, did not go to National Defense, was to maybe have a form signed, a consent form, along with when they're signing other forms as they are being released, to allow their medical information to be transferred to Veterans Affairs. So first off, I would like to know if you think that would make a difference, and if you think that could be a recommendation that we have in this committee for this particular study that would go to National Defense. And secondly, I know that you've been speaking, Mr. Bouchard, about a program that's recent, that there's been a transition program, and I'm wondering if you can explain a little bit further, specifically what in the last couple of years has been done in order to merge these two departments, or these two departments together in order to better offer services to our.
Thank you very much, Mr. Chair. I think, when you look at the CAF transition group, and I'll give the floor back to Commodore Bouchard, was really a jewel of the SSC in 17. So providing that transition where in one place, all the services are being provided, and then we are integrated with Veterans Affairs Canada for our members. So Dan, I'll give you the floor again.
Yes.
Thank you very much, ma'am, Mr. Chair. So the intent of the transition group and various transition centers across Canada, there are 32 of them, is also to centrally provide these services to not only our ill and injured, but all the regular force members transitioning out. And we're focusing on the families. Retention is always key. We're trying to retain our folks as much as possible and trying to transition to another career within the Canadian Armed Forces. But when a decision is made to release from the military, then that continuous care, so a transition advisor is provided to the member and their families, and they oversee a transition plan. They oversee a five-step process from what we call the military to civilian transition. So the decision to transition, their understanding of it, they have a plan, it's monitored, there's some training provided to them, and then there's a support continuum across. But by having Veterans Affairs Canada embedded with us at the transition centers, we can ensure that continuity of care. So as of this summer, 75% of our transition centers will be established, will be at our full operational capability, and we expect to have the full spectrum available, all of the transition centers, by April of 2024.
And if I may add, that when we look at the full spectrum, it is the full spectrum. It's financial, it's insurance, it's VAC, it's medical, it's physical fitness. It's the entire, and it's for our members, but also their family, to ensure that they're fully ready to transition. I've been wearing this uniform for 36 years. So the day I decide to release from the military, I lose my identity. Let's be honest. So how do we empower our people and their family to do that graceful, and they're ready to transition to a civilian life or to veteran life now?
Thank you. So just to be clear, would you recommend that a consent form be signed upon release in order for the information to be transferred to Veterans Affairs so that they can have the information necessary when someone shows up?
Thank you, Mr. President. So this is already happening. That's the process. That's the process by which the medical file is being released to either the member or somebody of their that they choose that they want it to be released to, whatever, if it's a family physician or a psychiatrist or whatever. So this is the process. The challenge of that process is we need to go from an electronic system, print it out or putting on a memory stick, and transfer it back to a civilian system, which usually require a full printout and rescanning. So the process is not smooth. It's not only us, I guess, at our level, but definitely we're trying to ease that. The beauty is within the transition groups, we have nurse case managers that are ours, that works for the CAF, that are responsible to ensure a smooth medical transition for members who have been identified as to have medical issues at time of release. The challenge we have is if a member do not disclose that issue at release and after develop a health issue, then there's potentially an access issue there that I know VAC is working on, but we're potentially losing those. I think with the new transition program that Commodore Bouchard is working on, we're going to catch more of those people, but that's still a challenge in my view.
Thank you for that, Madame Lambropoulos. 2.5 minutes, Madame Normandy.
Merci beaucoup.
Thank you. I'd like to come back to the remote medicine, the telemedicine that you refer to. MAPLE is mainly for active military families, and in particular it's civilian doctors or physicians rather than military physicians. Has there been an assessment to see whether we could have something similar with telemedicine with military physicians for military who are in transition? No doubt there's more trust with a military physician compared to a civil physician. Is this something that's under study? Thank you, Mr. Chair, for that question. MAPLE has two facets. There's one aspect that looks at our families when they move in a new province. If they don't have access to medical services, they can turn to MAPLE services through the morale and welfare services. But we've also got a service for veterans who are released from CAF. They become veterans and they move to a new province and they don't have access. So they too can turn to the MAPLE system. So I'll turn to General Bilodeau to talk about telemedicine on the military side of things. Thank you, Chair. Yes, French, yes. We've always done telemedicine. Majority of the time it was by telephone, where a physician was talking with the patient, for example, to renew medication. Of course, with the pandemic, that's really accelerated the technology to allow us to do telemedicine in a different way, for example, using video conferencing. And we've implemented that because we didn't have a choice, in particular in the first months of the pandemic when everything was closed down. That was the only way when we could have access to our physicians and give them the right treatment they needed. The challenge that we've got is that our telemedicine system is not fully integrated with our e-medical files, so there are some issues there in terms of coordination and logistical challenges that are going to be resolved in the next few years when we modernise our different systems. But this is clearly an added value to have telemedicine, absolutely, because some of our members are not co-located with medical clinics, and secondly, we can offer better support for deployed personnel outside of Canada when they need to have a consultation with a specialist, because many things can be resolved by video conference. You don't need to be there absolutely in person. In particular for mental health, we see this. We can give better access to certain specialities for our military with telemedicine.
That's Ms. Masson.
Working group, the duty to report in terms of what that the medical practitioners deal with, and how what is the progress of that working group to date?
Thank you very much, Mr. Chair. So the working group on the duty to report is continuing to work with the recommendation from Justice Arbour. This is is being led by Chief Professional Conduct and Culture with JAG. But on the side of the health service, I think it's important to remember that there's a difference on the duty to report, and I'll give the floor to General Bilodeau.
We, as licensed healthcare providers, have an obligation to protect confidentiality of the information that is disclosed to us within a clinical encounter. So that duty to report, we don't apply it for our healthcare providers, because if I was to do that and reporting something, an incident against the member's consent, I could lose my license, and I would probably lose my license. So none of our licensed healthcare providers are doing it, and this is, despite the policy, we can't adhere to the policy because we're going to all end up without a job. So for us, it's a non-issue, and we've already provided direction against the policy to protect our healthcare professionals from that perspective.
And if I might add, the chaplains are the same way also. Because of their duty, they have that exception on that duty to report. We're still working on the actual policy, but in actual day-to-day business, they're exempted.
So the CDS had actually mentioned switching over to a duty to respond, and I don't know if you wanted to add into that as well, but what is the deadline on that working group to actually report back on the duty report?
They're working very hard on this, trying to deliver as soon as possible with all of Madam Justice Arbour's recommendation. I'm not privy to the actual deadline and when it's going to happen. Sorry.
And duty to respond?
That's all part of that same file that they're working on the way forward to try to come up with a solution and put it into our policy and regulation.
Okay.
Madame Gallant, 5 minutes, please.
Thank you, Mr. Chairman. It was reported to me that last week there were 3 suicides on base Petawawa. Would you please tell the committee what number of mental health workers are currently available to members at Garrison Petawawa?
Thank you, Mr. Chair. I'll turn the floor to General Malcolm if you have the info.
Mr. Chair, thanks for the question. I don't have the specific numbers on how many folks we have in Petawawa. I can say across the country between military, public service, and contracted psychiatrists, psychologists, mental health nurses, and social workers, we have approximately 500 of those.
The medical personnel, including doctors, regular physicians, and pharmacists, how are they recruited into the military? How do you get the people who are actually serving the members? Are they all military, or do you have civilians as well to augment?
Mr. President, so we have an hybrid of healthcare professionals, some in uniform, and there's different ways by which they come to duty in uniform. Some of them directly from the civilian sector through a civilian healthcare professional, development program. That's the case for many of our physicians, nurses, physiotherapists, social workers, pharmacists, and so on. We also have public service positions in our clinics that are, for our physician, nurses, some of our mental health professionals as well. And obviously, we have some vacancies in those positions that we're backfilling through contractors.
Okay, and to contractors. So how are these contractors recruited?
So we have a contract with a big firm, that's Calian, who has that contract currently. And basically, they're responsible to meet our needs. So we're signifying the needs that we have for whatever professional in whichever location, and they're responsible to do the recruiting and to find those professionals.
So Calian is given a contract. So in essence, they get a cut of the salaries for the physicians, pharmacists, et cetera, they recruit. How competitive are the salaries of these physicians and other medical healthcare professionals to the private sector, to anyone dealing not through Calian?
Yeah, I can't, Mr. President, I can't comment on the specifics of the numbers of the contract. What I know is our contractor is adjusting their rate based on the cost of living and the ability to hire in different areas of the country. So a physician hired, for example, in Edmonton won't be paid the same as one hired in Nova Scotia.
Okay, so do we currently actually have any mental health providers on base Petawawa? And the reason I ask is, a number of years ago, this committee traveled to base Petawawa in the dying days of the Afghanistan conflict, and we visited the mental health center. So I drove there, but the rest of the committee took a bus. They were held up over an hour and a half by a general who was giving them a briefing before the bus even left. Subsequent to that meeting, we learned that while they were being detained in Ottawa, the people there at the center for the mental health on the base were scrambling to find people to make it look like the offices were actually occupied. And that's why I'm concerned right now that we actually have any psychologists or psychiatrists on hand, or do our people get loaded into buses and sent to Ottawa for their treatment?
Mr. Speaker, or Mr. Chairman, thank you for the question. So we do absolutely have mental health practitioners in Petawawa. I did a unit visit there less than 2 weeks ago in the new facility. So we absolutely do. There are times, however, when if members in Petawawa require more specialized services, that they can be referred to practitioners here in Ottawa. But we certainly do have mental health providers in Petawawa.
Mr. May, 5 minutes.
Thank you very much, Mr. Chair, and thank you to all of you for being here and helping us kick off this study. General, you talked a little bit about Seamless Canada, which I obviously have an affinity for as co-chair. I have the opportunity to co-chair that steering committee with the Honourable Mary Wilson from New Brunswick. Last year, of course, and you talked a little bit about this, we were able to get the provinces to waive the 90-day waiting period for health cards, not just for CAP members, but for their families. We are meeting again in Gagetown next month. My question to you is, what should that steering committee, in your opinion, be addressing next?
Thank you very much, Mr. Chair, and thank you, Mr. May, for the effort and co-chairing that Seamless Canada, because it is very, very important. Again, when we look at the military, the strength behind our uniform is our families, and we are all tracking the recruitment and the retention. And one of the main reasons that people leave the military is the impact of service on their family. from a point of view of, again, healthcare access, because, by the time you get on the list of having access to a doctor, you're moving again. It's the same thing for childcare. It's very difficult to find childcare every time you move. Spousal employment, because, again, when our members are posted, then their spouse needs to find a new job in the new location, and usually, you end up at the bottom of the list again and the lowest salary. So those 3 lines of effort are actually, I think they're the core of Seamless. And if the provinces can work on those 3 lines of effort and finding, it's not going to be magic, okay? There are small victories that we have to achieve through the years to facilitate those 3. Honestly, those 3 areas of friction when our members are moving across the country. For me, that's the core. I'm a mother. My husband was in the military, and raising 2 kids and having to wait for a child access when you're deploying, when you're working crazy hours. It is so stressful. If I had une baguette magique, and that magic one, for me, that would be access to childcare. It's great if we can look at subsidized childcare. That's great for our members. But having access is absolutely essential for our service member to be able to do their job, to be operational effective, so that you don't have to worry what's going to happen to your kids. I land in a Seeking in Halifax in a parking lot, and it's 5:45, and my husband was deployed, and I'm like, oh my God, who's gonna go get the children? Because the MFRC closes at 6, and what are they going to do? Because we don't have family members, because we are not posted where we have family members. So that access to childcare for me would be critical, and we're working very hard, but if I had one wish, that would be that one.
Thank you, General. I was in CFPS Guaymolt a couple weeks ago, and I had the opportunity to connect with the Family Resource Center on the base. I'm wondering if maybe you can take a moment just to sort of explain that to the committee, and is that a model that we are hoping to expand to other bases?
Actually, the Military Family Resource Center, I think they were established in the late 80s, early 90s. My history fails me, but in that area. And it's a jewel, too. It's a brick and mortar area where our families, our service member can go there to seek support. Again, from the family support, like homework, support to our children doing homework, but also mental health, socialization. Some of our military family center have daycare, but they're provincial run daycare, not by the military, but there's a location there, a daycare there. So many of the services that are being provided for our spousal, a network of employment opportunity at the tactical level, again, in different communities. It's interesting because Australia came for a visit a few months ago, and they went and visit our Military Family Resource Center because it's something that they don't have, and there's something that they're going to create for their veterans, because veterans have also access. Family members have access. We don't turn anyone from accessing the programs that are being delivered at those Military Family Resource Centers. So a jewel. And I would encourage that if you want to go visit, we can provide a session on what they provide, because it's incredible.
Thank you.
Mr. May. I must admit that showing up at daycare with a Sea King is pretty impressive.
Mr. Chair, I didn't make it.
Yeah. It's almost as good as landing on top of a Tim Hortons. Yes. Madame Normandine, 2.5 minutes. Hang on. Yes, it's Mr. Kelly. Yes. Colleagues, before Mr. Kelly, I propose two more 5-minute rounds.
Okay.
Is that right? Okay.
Yeah, that'll...
Sorry about that. Go ahead.
Okay. All right, so I'm actually going to carry on with the Military Family Resource Center, because that was identified within the Total Health and Wellness Strategy, and I want to talk about the status of the goals set out under that strategy. So how much of wait times for mental health services has been reduced through the expansion of the Military Family Resource Centers?
Thank you, Mr. Chair. As you're tracking total health and wellness strategy release in March of 22, looking again at that holistic evidence-based approach to health, looking at the physical, the mental, and the spiritual. On your specific question, and I know that there was funds provided to the MFRC to increase, again, the support they provide to the families. I don't have that data.
Telemedic service improvement, is that, do we have a measurable improvement on that one under this strategy, or is it?
Well, that MAPLE, that telemedicine initiative, was created based on the total health and wellness. So that MAPLE services that is available to our families as they move across the country, that is a clear initiative that was produced.
I'm looking for measurable changes. Have we seen improvement?
Well, we can certainly give you the numbers
please.
of how many people access the MAPLE from our families.
Okay, that would be great if you could provide that to the committee. So under the total health and wellness strategy, the strategy was included the hiring of 30 additional occupational therapists and 48 additional nurse case managers to support recovery. Have those hires taken place? Are those personnel now in place?
Thank you, Mr. Chair. I'll give you the floor there, Marc.
Yes, thank you, Mr. President. So we've done a first wave of hiring of case manager and occupational therapists through the first wave of funding that we had. We're receiving this year a second wave of funding that will allow us to complete the hiring process for.
Okay, so you can't get the 48 is contingent on receipt of the funding. That's
exactly.
Okay,
so
thank you. So the strategy included the establishment of additional Office of Disability Management and additional regional offices. Is that taking place?
We will need to provide that answer
okay,
later.
Fantastic. If you don't have an answer, that's great. You can if you can undertake to provide it later, and then we can get more questions in. We've heard that access to family physicians, we've heard this even today, for families is difficult. How many members' families currently lack a family physician?
We don't have that data there, sir.
Okay, if you don't have it at your fingertips, or the forces doesn't track it.
Well, we can certainly ask if we're tracking this, but
Okay,
because
please.
the movement and the agility of the forces and data
Okay.
change daily, but we'll look into this and
Okay.
see if we have access.
I think
to
that would be an important one to be tracked. If we're talking about all the factors that affect the ability to recruit and retain, and knowing the status of families and their ability to access basic medical service for their families would be something I think that we'd like to know about that if there's data. If there isn't, I think there probably should be. How many members' families lack access to mental health services in the communities near where they're stationed? And I say, many members are stationed in Canada quite far from large urban centers, so this is a real challenge. Do you know how many members have access or lack access?
Members or family members?
Family members. How many members' families do the families have access to?
And again, this is not something I have on hand. Hopefully, we are tracking because again, this is part of the evidence that we need to better understand as
Absolutely.
we look at gaps into recruitment and retention. But again, you got to remember that this is not our mandate, but we need to facilitate that mandate for that recruitment and that retention of our
Okay,
people.
if you could ask your staff if that data exists,
Mhm.
please have it sent to the clerk of the committee. Do I have any time left at all, Mr. Chair?
15 seconds.
Oh, well. All right, well, I won't get an answer even if I squeeze in a question, so.
Thank you, Mr. Kelly, for that generous allocation of time.
Yeah.
Mr. Souza, 5 minutes.
Thank you for being here and enlightening us on some of the challenges that you face. And some time ago, my uncle was a young doctor in the Navy, and it was seen as a practicum for him. Like, he ended up going back as a civilian into pathology and forensics. It seemed as a sort of a launching pad in order to get the big opportunities that exist. And yet, with the great demand that seems to be happening with mental health that's now coming upon us, how are you? And I understand the challenges, and you're explaining to us the concerns that we all share. So how are you attracting people to become doctors and nurses and practitioners in the military?
And when you look at military service, for the entire CAF members, it's that purpose, okay? That purpose to serve, that meaningful employment that needs to be in every new applicant. Now, why people join after that depends on, their respective situation. I'll turn the floor to General Bilodeau, who might have a better perspective on the medical side.
Yeah.
Yes, thank you, Mr. President, Mr. Chair. So we are hiring into 19 different healthcare occupations. So that's...
I can't hear. Sorry, go ahead.
Yeah, so we're hiring into 19 different healthcare occupations. So obviously we need to have a targeted approach for each of those because they are not trained in the same type of schools, they're not trained in the same environment, same locations in the country. So we're trying to have a very targeted approach for each. So we're going, for example, for physicians, we're putting advertisement in medical journals. We're going to med schools to do presentations about what it is to be a military doctor. Usually we bring somebody in uniform to talk to those med students as well, so they understand the environment, they understand the conditions, the benefits, everything we offer for them as an exciting career. And we're doing that through also a network of specialist recruiters that are specialized in recruiting healthcare professionals. So there are people working full-time for us in different areas of the country where the main focus is really to recruit healthcare professionals on our behalf. So obviously we're recruiting a lot of people, but a lot of people are leaving after their obligatory service because they've just decided to do something else in their life. So retention becomes a challenge for us, and we need to do better, I guess, from a retention perspective, trying to make sure that we keep them excited while they're serving so that they are willing to serve, creating that sense of identity as well that General Bourgon was talking about, that sense of purpose, that...
Because it's a unique group that you have.
Yeah.
Is it used as a test also? You know how they try, like in terms of sharing, doing research? Is the membership called upon at times to be used as in that regard so that they can actually have a more controlled group by which to monitor? I mean, willingly, obviously.
Yes. So there's a bit of research happening in our organization, if that's the question. And some of our professionals are interested and are doing research. I fund a health research program from my budget allocated. So yeah, we have a captive population that is easier to study, I would say, than the rest of the population. I would say it's not a majority of our people that are interested in research, certainly not early on in their career, but we definitely have platform for our people when they're interested.
Yeah.
And a lot of our medical practitioner we get through with internal transfer within CAF. So they join in an occupation, and then they fall in love with the CAF way of life, and then they apply to become doctors or nurses and join in. So we're seeing a lot of internal transfers, but none of us are doing this for the money. I mean, the financial security has to be there, but it's that purpose and that meaningful and the desire to serve. That's who we want to go and connect. So that's our challenge.
Thank you. Thank you very much.
A little less than a minute.
Well, that's even better. So the challenges that you've associated with in respect to accessing health care, and I suspect in some remote areas it's very difficult for you to share the civilian, whatever country you may be in. How do you deploy some of that? Like, you need to station people there for a long period of time in order to then substantiate or having a strong base of medicine and support for those members.
Thanks for the question, Mr. Chair. So basically, the analysis is done in terms of what the local resources are. We do have 2 permanent standing clinics, one in Guyland-Kirchen, one in Shape, that are able to provide some support to folks in Europe. And then when it comes to specific deployments, the assessment is made, what's available locally, what are our other allied resources that are there, and we develop a medical plan in order to ensure that we have continuous support for our folks, which ultimately, if there's a big issue, that they're transferred back to Canada.
Thank you. Mr. Souza. 2.5 minutes, Madame Normandy.
Merci beaucoup.
Thank you very much. I'd like to hear about whether you already have a partnership between the recruitment school in Saint-Jean and the community of Saint-Jean-sur-Richelieu, because there's a suicide prevention centre that has a room reserved for recruits, and it's paid for by the CAF. It's a win-win. They can get a good service, a specialised service, and sometimes for a recruit to be able to get out of that crisis situation can be very positive. So is that the type of partnership that you're going to roll out elsewhere? Because perhaps we're going to hear from people from the prevention services, but I'd like to know whether overall you've got that as part of your approach. Thank you very much for that question. We've got many community partnerships throughout Canada. We very much encourage the leadership in our clinics locally to develop these partnerships to support members, and these relationships are essential to ensure there's good follow-up with our members, because we don't always have all of the services within the walls of our military clinics. So we need to buy the services from provinces and from different community services. The beauty of this is that we've got a contract that allows us to do that easily with Medavie Blue Cross, so that we can facilitate the payment for all of these services that we need in terms of healthcare for our members. These are partnerships that are built up over time and improve over time to make sure they meet our needs. And they allow us to ensure that our members can come back up to service level where they can continue with their work. So who ensures that these bridges are built with these services to see whether the service exists, or is it the community that comes in and offers their services to the armed forces? How does it work? Well, there's several ways that they come to us. Sometimes it's local initiatives from our own clinical teams who develop these partnerships. But sometimes it's people that come to me directly as a general surgeon. I pass that on with civil partnerships that I've already developed personally. So there's several sources. But we try to encourage our local teams as much as possible to develop these links so that we can create these relationships and then offer the best care to our members. Would you like to add something there?
General Malcolm is catching on. That's right. That's right. 2.5 minutes, Ms. Masson.
I wanted to follow up. So in one of my questions, you had referred to provisions provided by OSIS in terms of mental health. But that isn't actually applicable to sexual trauma and the service of sexualized trauma and experience within the military. And so I know that that's referred to SMRC. However, in terms of that transition, when members are ideally served by SMRC, that doesn't happen for veterans. So how do you manage that transition for people who are experiencing sexualized trauma?
I'm not sure I can answer all of your question here because it's outside of my field of, my wide responsibility. That one is not in there. But when we look at the military sexual trauma and the work that is being done on the OSIS, the organization that Commodore Bouchard, that great network is being replicated for MST survivors. And this is being led by the SMSRC, of course, but based on the development of OSIS. So they're kind of replicating the same system because it's working so well for operational stress injuries that the MST network and survivors will be developing that same system. So I can't answer more than this because that is a responsibility of the SMRC to provide. But I know that OSIS is being used as the tool to provide that MST support to our survivors.
Is that information something that you can get to this committee in terms of timelines that we'll see that progress or plans for it?
We can take this back as a question for the SMS. They've changed the name. Merci. There's an S more now in, but we can ask them to provide an update on their MST support.
Okay, perfect. In terms of, you had been talking about the Medavie Blue Cross services provided to members. can you let me know what the timelines for renewal for those benefits and policy agreements are for the CAF? One of the concerns that I heard were for chiropractic services. There's a lot of requirements. Obviously, service members, they deal with a lot more, and so there have been requests for access to chiropractic, but that's not provided through Medavail, and they're worried about the agreements being renewed and what will be included in that.
We'll have to take that question under advisement. Ms. Masson's very clever. She asks her question with no time left. Very clever. Yes. Yeah, yes. And you're going to get answers, but you're not going to get it within the 2.5 minutes. Mr. Bazan, I have as, no, Grant Newman.
Thank you. What I'll do is to follow up with the question that didn't quite get answered in the last session from my colleague. And could you possibly provide, or could the CAF survey families to determine the rates of access to physical and mental services that we could include in draft recommendations? Because from our perspective, if we can't measure it, we can't manage it.
You know, in the CAF and D&D, there's a very robust survey program, and I will ask the question with my Director General of Personal Military Research on if that is already, it might be, you know, my gut feeling tells me it's already a question that they're asking about the caveat to access to childcare, access to family, mental health, and medical. So I will ask that question, but I'm like 90% certain that it is being done, but yeah.
These are the number one reasons why people are leaving or not joining, then I think it's super important that we look into it and get the numbers to support the decisions moving forward. Next, follow up from my last ask earlier in the session, we were talking about civilian doctors and doctors in general for the CAF. Do you think national defense, is there an opportunity for national defense to help with foreign accreditation of new Canadians with regards to family doctors?
Can you repeat that question and potentially explain it a little bit more, please?
Certainly. So my ask is, do you see an opportunity for national defense to help with foreign accreditation of new Canadians?
Okay, so I'm just going to confirm. So you're looking at national defense to take a lead in the accreditation of the qualification of new residents that come in with a medical or a health service background?
Correct.
Okay. Sorry, Mark. Show your way.
So this is definitely outside of our mandate. There are national organizations that are responsible for that. The Canadian Medical Council is being one of them, and obviously all the regulators in each of the provinces.
Okay, then moving forward, with regards to mental health, the 2023-2024 departmental plan acknowledged that the aim was to improve mental health support by reducing wait times for support and services. Could you speak to the current wait times and what is the central cause of it?
Yeah. Thank you, Mr. President. So there's a challenge currently in healthcare, not only in the military, but overall in the country, as you know. There's an increase in demand overall for healthcare and especially mental health services. That is challenging the system overall. There's just not enough mental health healthcare providers in the country currently to meet the demand. Obviously, this is impacting us as well because our members are a sample of Canadian society. So that demand for healthcare has increased also. That trend started, by the way, before the pandemic, and it just was exacerbated during the pandemic. I think there's a new set of stigma that are not as present as they were before from a healthcare perspective, which is good. You know, I think it's going to bring more people in care earlier, which probably will improve the overall outcome, I guess, of all of those people that are suffering from mental health issues. But this is currently creating a lot of pressure on our systems. So what we're doing about that, obviously, we're still trying to recruit as much as we can to have our piece of the part, if you will, from the mental health care providers' perspective. We currently have 50 active hiring process going on through our contractor, through Calian, to bring additional mental health professionals. It's not easy because we're in competition, obviously, with our colleagues from the province, and we can't afford to steal everything from them either. You know, we need to share in some ways. What we're doing, although internally, is we're trying to relook at our program and the way we deliver mental health care and see if we can become more efficient, if we can responsibilize more patients, if we can stick to our patients less than we are currently. So all of that is part of what we're doing. There's lots of now application, for example, online to do some mental health treatment, if you will. So we need to capitalize on that. I think that's going to be saving resources for us and allow us to treat more people if we do that. But yeah, an ongoing challenge that we're working on actively.
Okay. And how are you transitioning other supports following, so speaking with former CAF members, so how do they transition to other supports following their time with CAF to ensure long-term support for members, for veterans?
So I can speak to the medical aspect of it. There's other support, obviously, but the medical aspect of support, as I said, I have a responsibility to make sure that all of our members who have a medical issue at release are transferred safely to a healthcare team post-release. We're doing that through our nurse case managers that are the main pivot, I guess, to facilitate that transition. And then we need to liaise with the provinces and territories as well as Veterans Affairs. You know, so that's three partners basically dance that need to happen at time of release, which is being challenged now because of lack of access to healthcare in the civilian sector. And this is why we have that good mechanism that allows us to potentially keep member a bit longer to make sure that that bridge is done properly and safely.
Okay, we're going to have to leave the question there. I have Ms. O'Connell as the next. It will be you. Madame Lambropoulos, 5 minutes.
Thank you. So I'm going to continue the conversation about mental health. You mentioned earlier that if somebody is a veteran and their mental health condition comes out after, as is often the case in PTSD cases, which is something that a lot of veterans deal with, that there's an issue in terms of receiving the services or in terms of that transition. I'm wondering, is it mandatory for members of the CAF to receive mental health support? Is it mandatory to see a psychologist, social worker, all of the psychiatrists, addiction counselors? Is there somebody that's automatically checking in on members periodically, regularly, in order to make sure that people are not being missed out on? And what is the process for that in general?
Yeah, thank you, Mr. President. So lots of different touch points with our members throughout their career that are allowing us basically to identify when they're suffering from mental health issues. That started recruiting. You know, the first day they enter a recruiting center, we're asking them if they have active mental health issues. And then it goes on, through our periodic health assessments that we're doing on a regular basis, cyclical basis, based on their age and gender. That goes through the pre-deployment screening that we do before they go on any mission. That goes through the post-deployment screening that we do when they come back from mission. That goes through any touch point we have with our members for other reasons than a mental health issue, So that's an opportunity that we have basically to seek and ask if they are suffering in any ways and making sure that they're offered the support that they need based on their disclosed condition.
And I think Admiral Commodore Bouchard wants to add something.
Thank you, Mr. Chair. I would like to add also that part of the family support system that we have, obviously, in the transition process, we have a family liaison officer for the more complex case, and there's also a family transition advisor for the less complex cases, but they go through, with the families and the immediate supporting members, we go through a process to ask these types of questions and to develop that type of understanding for the member that's proceeding on release, and to make sure that we have these opportunities also to see if there's any red flags that we should be looking into.
And I just want to add too that we do mental health readiness. The Road to Mental Health Readiness is a training that everyone needs to do at different steps in their life too, before deploying, coming back from deployment, but on basic training. So people are familiar with that mental readiness, the spectrum outside of the health services, so that leadership and members are tracking.
Would you say that members feel comfortable disclosing if they are going through a mental hardship? Would you say that it's often that members will say that they're going through something, or do you think masking is something that's regular in the armed forces because already these people are so tough and have to be the defenders of our country, so it's very hard for someone to admit when they're actually going through something? I think COVID-19 and just seeing how many regular Canadians or civilians suffered from mental health issues, and it came out during the pandemic, I can only imagine that going through the traumatic experiences that someone in the armed forces would go through, it's automatic that they must need help in some way. So if you can comment on that.
Thank you, Mr. President. Thanks for the question. Yes, there are still stigma, but they're less than they were 20 years ago, and they keep reducing, I guess, in some ways. The reason for that is I think we've never normalized what it is to be suffering from mental health, and we made it normal. There's still a concern for some members that it's going to impact negatively their career, though, and that's the biggest stigma we need to fight against. And we're trying to work on policies that will alleviate that. For example, there was a policy in the last few years where you can still be promoted even if you're being treated actively for a mental health, for any condition, in fact. So this is an example of policy factors that are impacting basically stigma. We still need to work on that, though, and I think leadership is critical there. That's where the military leadership, the chain of command, is critical in reducing those stigma and normalizing access to care. That's why we're working in partnership with the military chain of command and the members, trying to make sure that we all understand that it's a shared responsibility.
And before I let you go and I let him cut me off, I just want to mention perinatal mental health. It was brought to my attention that once women exit the forces, they begin having children, or in many cases, and they recognize that the trauma comes out while they're pregnant or afterwards. And so, just wanted to put that on your radar because it's not something that's discussed very often. It's something that we need to start talking more about. In terms of offering medical care or mental health care in that area, like for the younger women who may plan on starting a family soon, just so that they're aware and so that your mental health practitioners are aware as well, because it's not something that's discussed yet regularly.
If that can be worked into another line of questions, that would be very helpful. Colleagues, that completes their third round. I propose one more 5-minute round, and what I have, and I'm not sure who the Conservative is, but Mr. Bazan, I have O'Connell after that, Normandine, Masson, Bazan again. Kelly? Okay, so Kelly up, and the Bazan last, and I have Madame Lambropoulos as the last. Mind you, McKay might like to get into something. Just hinting. Okay. With that, Mr. Kelly, 5 minutes.
Okay, thank you. I just want to start my clock. All right, now, so just getting back to the total health and wellness strategy and its goals. One of them is introducing the Workplace Harassment and Violence Protection Center of Expertise. Is that up and running?
Thank you very much, Mr. Chair. That part of the total wealth and wellness strategy belongs to Chief Professional Conduct and Culture, so I cannot comment. It's part of our strategy, but does not fall into my Chief Military Personnel mandate.
You're not sure whether it's running or not?
It's running. I just don't know how much progress they've made, because I know that they wanted to hire more people and make it more robust. Okay. So I cannot give you an update.
You don't know how many complaints or appointments it can handle in a month?
No, sir.
Okay. Perhaps then on the CAF transition group, transition to civilian life, how many members are currently in the transition group?
I'll give you the floor there, Dan.
Thank you very much. So for our ill and injured posted into our transition group. At this time, there are 1,502 individuals, sir, across Canada.
Okay. And how long normally is a member in transition?
It varies between with each individuals. Generally speaking, it's 3 years, a 3-year period.
Okay.
But we have some that have been up to 6 years with us, sir.
Okay. The number that are in transition, is that static? Or do you see that becoming a larger or smaller number at a particular moment?
At this time, I don't have the trend with me. My apologies, but we've seen it's been at around 1,500 over the past 2 or 3 years.
Okay. How are Forces members made aware of the supports that exist?
There's actually for our ill and injured, those that are posted to us, there's a service coordinator that will do the transition process with them and will coordinate their services with them and their families.
Okay. So implementing the women's health framework to support women's health care in military, how far along is the implementation of the women's health framework?
I'll provide the floor to General Bilodeau, that he will talk on the health side, and I will just add after on the CFMWS and what they're doing.
Yeah, so we're just starting. We're now building a team. We're hiring people in our clinics, and then the work will start after that to start looking at our research framework, our surveillance framework, our prevention framework, and our healthcare framework. But we need people, obviously, to do that, and those people are being hired as we speak.
Okay. Go ahead.
And on the CFMWS and the occupational fitness, we're a little bit more advanced because we leaned forward last year to ask CFMWS to start delivering on their line of operation. So from the first initiative is looking at women recruits, and as they go through Saint-Jean, trying to provide support before they arrive in Saint-Jean from a physical fitness, because we know that women have a deficit, okay? Physically, we have a deficit on that fitness side, so that we provide support ahead of time, and we now have a physical fitness program that is available online to ensure that women, as they're waiting to go to Saint-Jean, they have about 3 months that they can start workout and they can improve their physical fitness.
So you had a very specific target on base, wing, and unit fitness. You talked about hiring 44 additional staff. Have those additional staff, all 44, been hired?
I cannot guarantee that the 44, but I know that CFMWS has leaned forward and hired everyone that they were asked to hire because they're a bit more flexible in their hiring procedures, given that they're not public employees. They're part of NPF employees, so I would say yes.
Okay. So do you know how are they recruited then? Say that again.
It's a non-public fund employees, so CFMWS has a different construct than public employees. So I will not go into details because it's very complicated and we won't have time.
All right, I think I'm out of time. Yeah.
Thank you, Mr. Kelly. Madame O'Connell, 5 minutes, please. Are you? Jennifer? 5 minutes? Okay. Why don't we go back to Jennifer, are you hearing me? No, you're not. Okay. Okay. Yes? Well, I just was thinking that Emanuela asked a really key question, and I thought it deserves an answer. Okay.
Yeah, she can't. For some reason, she can't hear. She's just texted me. Go ahead.
So I'll continue on the question of perinatal mental health, and I wonder if you can tell me if there's anything that is being done. I know, I don't know if some members are that are in the armed forces are having children and are dealing with this as well. But is it something that's on your radar? Is it something that that you've been dealing with?
Thank you, Mr. Chair. So we're currently in the process of hiring specialists, OBGYN, that basically would help us providing advice to build a better program there. Advice as to how to better manage from a healthcare perspective our women that are in the perinatal period, but also making sure that we're preventing any potential injuries, because we know that's a period prone to injuries as well. So we're working in partnership there. So we hope by then to be able to build a better prevention program, but also care program. We won't reinvent the wheel, though, because a lot of it have already been done by our colleague in the US and the UK mainly. And that's why that international collaboration is so important. We were lucky in February to host a symposium in the Canadian Embassy in the US, where we invited our partners from the Five Eyes community, trying to share what we're doing respectively from a women's health perspective. And we agreed at that conference to keep working together to develop those clinical practice guidelines that would allow us to move together, I guess, in improving women's health in the military.
And on that aspect, from again physical fitness, emphasis done on pre and postpartum at our gym with experts, pelvic floor therapy that you were going to see across. I believe it was in Petawawa that was done for the first time. Now mothers or parents with their newborn can go to the gym and have physical fitness that is developed for them, so that prevention and recovery. So it's really good initiatives that are going forward.
I'm happy to hear that. I guess that's why we haven't heard it on like the national defense side, but we've heard it more from veterans who don't necessarily have that support and who it comes in later. So, I guess that'll be one of our recommendations going forward, or maybe we'll look for a little bit more info on that. I'll pass the floor to my colleague, Mr. Mayor.
How much time do I have, sir?
3 minutes. 3 minutes.
I wanted to kind of talk about, and I know we've sort of talked about some of the gaps in the system right now, but I'm wondering if you can sort of take us through the process or the point in which, or if there is a point where a person in care is then being handed off to a provincial healthcare system, and I'm thinking like cancer treatments and things such as this. I'm wondering if you can sort of explain the level of healthcare that exists within the military and where there's that transition to public care.
Yeah, so as General Malcolm described earlier, we're basically providing enhanced primary care in our clinics. So in most of our clinics, the 37 that we mentioned, we have a primary care team that is usually led by a family physician. And many of them are augmented by physiotherapy, mental health. Those are our two main areas of focus from a healthcare perspective. And in some of them, we have some diagnostic technology like X-ray and lab. Not all of them. So everything that goes beyond that, including specialty care, including hospital care, we don't have it in the military. So we need to outsource.
MRIs within.
We do not have MRIs. We have 2 deployable CT scans, but we don't have MRIs in our clinics. So therefore, every time a member requires services outside of that, then we do a referral. Like we do in the civilian sector, a referral to a specific clinic or specific providers to receive the care they need.
Is there any preferential treatment for CAF members with those referrals, or are they going into a queue scenario?
There's no preferential treatment, but if we have a special operational requirement that requires a member, for example, to have a knee arthroscopy in advance of others because we need them to deploy in 6 months. Mm-hmm. If we develop good relationship locally, we're usually able to negotiate, I guess, that access, if you will. We're trying to be careful with that because we know we're competing with all Canadians, so we need to be careful or we're managing it. But in some exceptional cases, I believe it's justifiable because that's the security of our country that depends on it, I guess.
Thank you.
Hey, 2.5 minutes, Madame Normandine.
Thank you. I'd like to come back to this question of mental health services. You've said it's important to make that more efficient and effective. So from an operational point of view, how does that work when someone is transferred and they were receiving mental health services? Do they have to start that from scratch with new professionals, or is there some follow-through? I imagine it's not the same thing with mental health services because of the question of trust compared to just a broken ankle where they just need physio. So could you give us as an answer on that? Thank you, Mr. Chair. The beauty of our system is that we have one e-medical file that's pan-Canadian. So when we document health, it's in the e-medical file and it's accessible everywhere. So it's easy to have a transfer of care from one base to another when they're transferred, or if they're transferred temporarily to another base for employment reasons. So we've got easy access to care, so it does make it easier to provide care. When it comes to the therapeutical relationship that we establish with our members, of course, that's a major criterion for high-quality healthcare and the support that we offer to our members. Fortunately, with telemedicine, sometimes we can facilitate continuous follow-up with a professional from another location when they're moved to this other location. It's exceptional. We don't frequently do that because most of our members, when they're significantly ill, they won't be transferred during that period. But if it does happen, we are able to have this continuity with telemedicine. Sometimes we will allow the member to travel to see a professional, but that's exceptional because with mental health cases in general, we can do that via telemedicine. And that was my next question. In fact, in certain cases, when there's mental health issues, can that be a good criterion to actually avoid a transfer while this person is getting more stable, rather than having this additional stress of a transfer loaded onto them? Yes, fortunately, with the relationship with the chain of command, there are certain limitations on employment. We have dialogue between the chain of command and the member to ensure that there's shared responsibility to make sure that we've got the sufficient conditions for the member to recover. Sometimes we may recommend that a transfer should be delayed to facilitate this care being provided.
Ms. Mattson.
I'm going to try and put two questions in together so that I can trick the chair into giving me more time. I would like to ask, I didn't get to ask you or get a response to, can you let us know the timeline for the renewal of the benefits for CAF members in terms of the Medi Blue Cross extended care? And then is the team considering the increased coverage for chiropractic services as I understand, has been requested by many service members? In addition, I have a colleague. He has introduced Bill C-206. It's a private member's bill that ultimately would change the National Defense Act, which makes self-harm a disciplinary offense. He wants to recognize that self-harm is obviously a mental health issue, and by removing it, it would actually take a step forward against a lot of that stigma that you're talking about, against the recognition of the fact that mental health is an issue that we address differently from a physician's point of view. Thank you.
Thank you, Mr. President. So on the question of renewal of benefits, there's two pieces there that I might answer, and I don't know if I'm going to touch what you're looking for. But first, we're in the process of renewing the contract with Blue Cross. And is that what?
It's a timeline, yeah.
Okay, so it's led by Veterans Affairs. So that's a three-department contract between us, the RCMP, and Veterans Affairs, and they're the lead. So I can't comment on the specifics of that. Regarding specifically chiropractic, it's already included in our list of benefits, chiropractic care. So we are allowed to refer our members to receive chiropractic care, and it's basically funded through our payment mechanism with Blue Cross. So that already exists.
Okay.
On the aspect of 98 Shirley and the self-harm, so this is more of a legal question. They're looking into that legislation, but at the end of the day, self-harm due to mental health is never going to be actioned as a punitive way.
Right.
So
the point of the bill, and we've been told that is never going to be actioned, and so why wouldn't the act just be changed?
I mean, you got to go and look at unlimited liability and going to war, and you look at World War I and World War II, people cutting their fingers so not to be. And I know it's based on history. mental health and in that aspect is will not be used. I think it's well protected on the health services, so it is something we have on our list to amend, but it's a question of priorities and sequencing because there's a lot of legislation that need to be modified right now, and we have limited resources and bandwidth.
Thank you. Mr. Bazan, 5 minutes.
And just want to quickly, we've referred to the total health and wellness strategy. I know that's not completely, it touches on parts of what you're doing in healthcare, but also touches other parts. Could you, I know that there's deadlines tied to that strategy. Would you be able to table in the House, how the strategy has been executed and whether or not we're meeting those deadlines? And then a few times in testimony today, we talked about the Seamless Canada initiative and how that's impacting, especially in the consistency and the continuity of care for CAF members as well as their families, especially when they're moving back and forth across the country. Could we have a copy of that agreement with the provinces tabled with committee so that we can see exactly how it's going to be implemented?
We'll look into this. I think every year we provide a report on the total health and wellness strategy implementation plan. So
I think we looked online and we couldn't find it.
Yeah, I think it's releasable. We'll go back and look into it. It might be in the process of making its way up to the minister for signature, but it's something that we have to do every year anyway. So we'll ensure that it's made available when it's ready to be made available.
Okay, thank you. Now, we support the government's announcement to expedite the pathway to citizenship and recruiting, permanent residents into the Canadian Forces. Have you looked at using that as a tool to actually go and recruit specific new Canadians who are trained in healthcare but are not having their credentials recognized here in Canada, but would provide that opportunity to have their credentials recognized while serving in the Canadian Armed Forces? In their fields of expertise and training?
Yeah, so the challenge with that is we're not a regulator. I'm not giving license to practice. So the College of Physicians, for example, for physicians are in the provinces. So they are the one who will, give them the authority to practice or tell them what they need to do in order to gain their permit. So that would be a very challenging space for us to get engaged in as we don't have all the levers.
I think it would be an opportunity for the Canadian Armed Forces to fill in vacancies and work with those colleges to ensure that those professionals are getting accredited while providing the care that our members need. Okay, so just moving on, going to the CAF transition group, we've got some of the numbers there. Now, not everybody originally when they go into the transition group said, okay, we're going to release you. Some of them we may want to retain and retrain. Do we know what numbers those are, percentages, success rates, especially finding people with, national security clearances that are getting more and more difficult, it seems.
Thank you very much for the question, Mr. Chair. I do not have the numbers because the transition group for all Reg Force members transitioning, we are not at full operational capability at this time, but we are tracking these numbers. It is something that I've asked the team to look at to make sure that we have the idea.
Could you provide those numbers to the committee then as well? Because it'd be interesting to see what careers they're transitioning from and into. Even if they're going to transition as civilians but go back and work for national defense, because I think there's opportunity there to take those people with operational know-how and to put them in on the civilian side. And talking about recruitment, I'm hearing that the percentage of women that have actually walked into our recruitment centers across this country is on the decline. We, of course, have had bad news with CAF for a number of years. I just want to know if you can confirm that numbers are only 8% of women, is what I heard, have actually darkened the doors of recruitment centers across Canada.
Thank you for the question, and that is not a fact, actually. When we look at the numbers of people, women, there's about 28% of the applicants in our recruiting numbers right now that are women. So 28% of women showing up to get recruited. The issue that we are seeing right now is that a lot of women are going for the same occupation Okay, a lot of the, again, Canadian and Canada as a society, we're still quite gender traditional roles. So they're going towards those traditional the occupation, mostly into the medical, the logistic, the support, and those numbers are actually limited. So that is where the issue is. If we could get, and I'm just going to finish here and stop. If we can get more women to go into the non-gender traditional role across the CAF, we could have 28% of women.
Thank you, Mr. Brizan. I'll take the last question. There's a saying that there are no atheists in foxholes, and yet we've managed to have almost a 2-hour discussion without discussing the spiritual well-being of CAF members. In my riding, the rhythms of a lot of my constituents are governed by their spiritual and religious affiliation, whether it's Muslim or Christian primarily. Yet we've had no discussion about the spiritual well-being of our people. Do you think that this is an impediment to recruitment?
Thank you, Mr. Chair. I said the word spiritual when I talked about the total health and wellness because, again, it's the physical, spiritual, and mental. And we have a robust spiritual section with the chaplain generals. And the chaplain general is responsible to provide chaplains across the CAF and D&D. And when we look at the chaplains, we've seen in the last 18 months a growth in chaplains, but a growth in the non-traditional faith of chaplains. So now that we have Muslim, we have Indigenous chaplain, we have a humanist chaplain across the CAF available because it is so important. And it's part of that command team aspect, that's part of that support at the tactical level. And the chaplain, regardless of their faith base, are all trained, and a lot of them actually have social working background. So on top of that social working help, they also provide that spiritual, way more spiritual, not based on a religion, but spiritual base across the spectrum. So it is an important piece of that total health and wellness strategy that we've been working very hard with the Chaplain General to broaden that spectrum of what is available for our troops.
Well, putting aside the distinction between spiritual and religious, of which many would say there is no difference, do you think that the direction that chaplains that represent or are affiliated with organized religions whose beliefs are not synonymous with a diverse and inclusive workplace are being excluded from chaplaincy? Because if a misinterpretation would pretty well eliminate all of the Abrahamic religions from any application to be chaplains in the forces. So I'd be interested in knowing how you square that circle, because it does, on the face of it, appear to be hostile to a large percentage of Canadians whose faith determines how they live.
Well, I think, we're looking at this as what is the role of a chaplain, and that spiritual is more important, and service to our CAF members. So right now, every chaplain that is coming in the CAF, regardless of their faith group, has to first respect the values of the CAF as serving every member and being inclusive. So that is the first. If a chaplain coming in cannot meet the CAF values because their faith restrict them from doing them, or their, honestly, the CAF is not a place for them. So the first thing is being able to serve and provide support to every CAF member, regardless of their fate, of their gender, their identity, and everything else. So that is being very clear across all of our chaplains. Now we have to, personally, I think that we need to provide our members also with their religious support. It is important, again, but every religion must be respected also, so that those services are available for all of our CAF members. So we are looking at a much more inclusive chaplain group, but again, respecting the CAF values and our ethos first.
Okay. Thank you for that. Right on time, too. Yes. I had 1 second left over. With that, I do want to thank you for your attendance here. Why are you waving at me?
I just maybe wanted to remind the chair we may have a quick question for the committee about travel.
Oh, do we have a quick question about the committee? Well, let me release the witnesses first. And again, thank you. You've given us a great deal of information on which to launch this study. I hope that ultimately the report that the committee produces will be useful as you go on. Committees have an ability to actually pull in a lot of information from both inside and outside, and hopefully move the ball forward as far as useful directions for CAF, which I think is ultimately our goal for everyone. So with that, thank you. And I'm being told not to bring the gavel down until we deal with which?
So just, Mr. May asked about this before the meeting started. The deadline for a travel submission for the committee is May 19th. We talked about it at subcommittee, but just to fill in all members, we are unable to extend the travel authorization or the budget approval that we have already received from ESPLI. And so if the committee wishes to submit a travel submission for the July to September period, we would need to do so by May 19th. It's a shorter process than it was before. Basically, what I would need from the committee to start the process is know where you would want to go, and then I can start the detailed budget process, which would then need to be approved by the committee at a later date.
James?
Mr. Chair, I just say that we want to submit that travel request. We want to add the UK as a stop to visit our troops that are training Ukrainian troops in Operation Unifier, and if we have to drop a location, I'd suggest that be Lithuania.
Okay. We're good? Okay. Just reminders, May 2nd, next Tuesday, is Minister Anand. Also, May 2nd is the deadline for witness submissions for procurement. May 5th is canceled. May 19th is canceled. May 9, 12, and 16, we continue our study. And the Polish Deputy Minister of Defense is coming May 8th. If you could let the clerk know just what we need, who's interested, put it that way. So with that, everyone good? Meeting adjourned.